but now there is an increased emphasis to improve community service and providing health care, primary health care to be specific in this country, to address these specific issues, so that the first thing a pregnant mother should be is to get in contact with a professional who can advise her what to do. This is the first thing I want to fire.
I think, I don't know. I think we need to look at what is being done with regards to the malaria aspect in pregnant women. The World Health WHO figure shows that 984 pregnant women die out of 100,000 in Nigeria. And 11% of this death is attributable to malaria. So the whole total of 89% is also further diseases. So you have to look at our health system in totality. The health system in totality that affects the pregnant woman, not only malaria. So there is other diseases, other things that come on a pregnant woman. But 11% of that mortality is malaria, and I think we're talking on this. But I just wanted to mention that we don't pick on this 11% and leaving the total health system that also affects the health of the pregnant woman in other areas. So the question is, how does a pregnant woman get to a hospital, not for treatment of malaria? I think the total thing is, how will a pregnant woman get
access health care?
And from 2000 to 2005, there have been an improvement, even from the malaria point of view. That there was an increment from 15 to 34% in pregnant women and children under 5 getting to the hospital for treatment within 24 hours. That is a fact now. So we are moving. We are thought that we'll get to 60%, but we got to 34%. And let us not think that more people are dying now. I think there is an improvement of people getting to hospital. Pregnant women are going more to the hospital. Visitation is increasing. And I think the nurses might be able to give us whether they're having more pregnant women coming to antenatal than they were doing before. So we are moving. Let us not look that we are stuck. We have not got to where we are looking for, but at least how can we now do more?
Okay. I just want to ask this question. Where do we we are in the city here in Lagos. We have the villages and things. The percentage of those pregnant women who are going to hospitals or who are not going to hospitals, where do we find them most?
The percentage of?
Yes. If you look at the quantum of people who get to the hospitals, pregnant women, and those who don't, where do we have the greatest number of those who don't go to? Do we have them in the rural areas? Do we have them in the cities?
Well, the likelihood is that somebody in Lagos will go to antenatal compared to somebody in my village, Ila.
Okay, so the next question is this.
That's the first thing, because the primary health care is just developing. And then there are other areas, the local things people say, they have native, they have traditional deliverers and everything. You can't be in Lagos and be looking for traditional delivery, you look for maternity.
Yeah, that's
so really, the issue is that in Lagos or in urban areas, we have more people going to antenatal areas.
Okay, that means that we need more work in rural areas.
But,
okay.
I think I have a little. Well, maybe Lagos will not be a nice place to give us an example.
Okay.
I'm privy to a study that was conducted in Lagos Island that showed that more than 50% that registered for the first antenatal don't deliver within the hospital. They go to TBAs, traditional birth attendants, to deliver. So these are facts, and we've said it several times. The problem here is that our pregnant women, they don't have confidence in the health facility to deliver. Many people have given various reasons why it is like that, but we still have that big problem that they don't come to health facilities. A study that was the National demographic survey that was done in 2003 showed that about 61% of the pregnant women attended one antenatal and 2 dropped. So that means they just come for the first time, take a number, and they don't come. And the way malaria and pregnancy prevention is, it has to be the IPT, intermittent preventive treatment, has to be administered within the hospital. It's directly observed treatment or therapy. So if they don't come to the facility, there's no way they are going to get the medicine. So we have to begin to look at what makes them come to the facility. When it comes to the area of the medicine, the federal government has done a lot. They've been able to buy enough, calculating the number of pregnant women that we are expecting in Nigeria. They've even surpassed that. But the issue is now for pregnant women to come to the facility and take it.
So that is the big question.
It's free.
How do we get the
It's
pregnant
free.
women to the facility? We'll round up with that. Dr. Yusuf.
I would just like to ask a question because I'm also of the mindset, perhaps because of my scientific training, to go with facts and evidence and, you know, research work. And I'm happy for the information that Dr. Ntadom has presented to us, the statistics of what pregnant women, the attitudes of our pregnant women, how do they assess health care? 61% attend one antenatal visit. Thereafter, what do they do? Because I know that our pregnant women don't deliver at home. Where do they deliver? When I was in medical school over 2 decades ago, I remember in those days of Olikoye Ransom Kuti being health minister that there was this groundswell of community-based health workers where traditional birth attendants were incorporated into the formal health sector and given some kind of training so that they can manage some basic health conditions that commonly befall the public. I don't know, I know, and those things were in line with promoting primary health care in those days. I don't know how the mindset of government is now. There they trained community health workers. They called them choose and chose. I remember in school then we had those choose and chose. And they also had the TBAs that were receiving specific training on orthodox treatment, because if you need to do a DOT for IPT now, directly observed therapy for preventive treatment, these are things that I think that community-based workers can be trained to do, so that we can begin to work very quickly to bring down the morbidity and mortality from malaria in pregnancy.
Thank you very much, Doctor. Yes, how do we get the pregnant women to the facilities?
I thought that Dr. Mr. Yusuf, as a practical mother, will do it better, but as a man, that's something difficult. But I think it's the sum total of our health system. It's not only of malaria or pregnant women. It is, even when you have the cut in the leg, you know, what do you do? What's our attitude? Our attitude is very restrictive. We do not go to the hospital. And that is, behavioral change is very important in all our health system development plan. Behavioral change of all of us. I'm sure that even some of these nurses, some of these nurses who are here today, that something happens to them, they are in the hospital every day, they still go somewhere to treat it. It's not impossible. But these are our behavioral change for certain things.
Thank you very much.
Well,
come to you. Let's
okay.
Your last line on that. What's your message? How will we get our pregnant women to come and make use of the facility that government has provided?
Well, Dr. Yesoro and Sekemefuna have contributed, all hands must be on deck. And we, apart from getting them to the facility, we should reach out to them like she has advocated, and it's very key, because there's no how we'll get all of them to come.
Yes. You see, first thing is for the government to be proactive about these issues, because there is no point anybody will go to a facility that is empty. There is nothing, no drugs, no professionals, nobody. You know, that's the first thing that I think what government now is trying to do. make this facility, equip them, get people to work, prevent migration, provide good infrastructure. You can take a nurse who has qualified in Lagos, take her to the village. She will not stay. There's no water, there's no light. She will run away. And there's no woman who will go to an empty place and sit down there. Doing what? First things first. Government must be proactive. It must be seen to be doing something. That's the first thing. Thank you.
Thank you very much. Yes. Tadam,
Yes, the issue with pregnant women going to the health facilities, many people have said that attitude of the health workers, what do we do? What are those things we do to scare them away? I think we have to look into it in addition to providing medicines and other things.
Thank you. Doctor?
Well, it's like what everybody has been saying, but the bottom line is that let the government make sure that the environment is conducive for the people to go to the clinic and hospitals.
Okay, thank you very much. So we are talking about we've established that the facilities are there. So we're talking about reaching out to the women, reaching out to the people to encourage them. If there are attitudes that are not encouraging them to come, that will change. And also the women themselves, okay, will also change their attitude and know that these facilities are there. They need to take advantage of those facilities. So we'd like to take some questions now before we run up on this segment. Because we have a segment where one or two of the discussants will still be here, and we'll call others to join them and take that. Yes,
Good afternoon.
My first question is this. Is there a relationship between pregnancy and jaundice? Because you see a lot of that in children. Malaria, pregnancy, and jaundice.
Jaundice in the mother or in the...
In the child,
Okay.
Not too long ago, I was invited by a doctor to come and see something. What is it? He's been telling me about this new development, the recent trend, something that is happening. Churches have maternity centers. Some of them don't encourage the use of drugs in any form. Yet, women will go there. Faith-based. And most of the very, very bad cases of pregnant women come from
taken to these places.
What are we doing as a government to control or make people to see that the best place to go when you have a problem or when you are pregnant is not to a church but to a hospital? Secondly, what are we doing as a government still? What are we going to do to make people realize, or women realize, that there's nothing in the hospital that helps them? I'll give you from personal experience. When I had my first child, a long time, I attended my antenatal with youth. When I get there, I see the crowd, I get scared. There are a few times I fainted. Just going there, and I will see, I will just go. And I never knew what really makes me to, whether it is the crowd, whether it is the heat, whether it is the people I see, I don't know. But I think there's something that repels us. Maybe too many people will wait too long, or what else. Even though Lagos State say it is free, why is it that pregnant women are not doing? We need to look at all this. Thank you.
I think we can take the question before we take another.
Yeah, maybe I just take the issue on the jaundice. Ideally, jaundice in a child could either be physiological or pathological. That is, it could either be just something that it will grow on its own. When it is occurring probably after 3 days of delivery, that means the child was actually not born with the jaundice. Then it is physiological. In the use of SP, when you look at theory in books, it will say that when you use SP at the get it to delivery period, that's very late pregnancy, it has the ability to displace, sorry, I'm going a bit too, it has the ability of displacing iron from its binding, sorry, bilirubin from the binding site. And it will not make bilirubin, which is actually the source of the jaundice, to be in the system, which has the ability of either affecting the brain and making the child having some diseases like canicterus. But from all the evidences available, it has not been documented that when SP, that is sulfadazine pyruvate, is even close to the late pregnancy, they've not been able to record anything. So what we are just trying to say is that the jaundice that is being recorded, probably one or two, has not been in any way connected with the use of sulfadazine pyrimethamine during pregnancy. So it is not as a result of IPT. But naturally, even before it was adopted as a policy in Nigeria, physiological jaundice has been there, and we see it. The only people think is that once you see a child with jaundice, they say, the mother used IPT. But there is no link, because it's been found to be very safe. So it couldn't have been as a result of the SP.
Thank you very much. Dr.
On the issue of the faith-based...
Yes, I think as a pediatrician, she has more to...
Well,
let's hear psychology, then we'll get to
Okay, the faith-based, you mentioned about people going to churches. Unfortunately, in Nigeria, our constitution and our legal documents does not force you to take anybody to any particular place. We've been fighting it. Even we lawyers from the legal point of view also look at how do we get education and health as a right, human right. In other countries, you have right to health. In Nigeria, it's under state policy. They say state will provide for you. It's not justiciable. You can't go to court. So on the other hand, you cannot say anybody who wants to go to his church for healing faith not to go. In the US last week, I was in the US, and then a child was diagnosed as having cancer, and the mother, they're still looking for her till today. Took the child body. The state went to court, and the judge has ordered that that child should be arrested and brought for treatment for cancer. In Nigeria, we do not have these rights and law. So somebody goes to the faith-based hospital. According to it, you can't force anybody because it is his right of choice. He decides that he belongs to X and they don't do blood transfusion. We've had many people live in the hospital. The doctor discharges the person. The doctor will not force you to have blood transfusions. So these are some of the conclusions in terms of faith-based. See, when you come to faith-based treatment, it's something here. And
so just a follow-up to this issue. There are two issues here. Because the issue of health for this is fundamental human right. You have your right to health. If it is the patient that rejects, treatment, that is a personal issue. He has a right, to decide for himself whatever he wants. But if it is coming from practice, then this is now a regulatory issue. Then that means there is a regulatory lapse that needs to be enforced. Okay. Because the issue, whether you are religious or this sectarian or whatever, has, the government has a duty on its citizen, to protect his fundamental human right. And if that person is sick and he desires treatment, he must get that treatment. And the government should enforce it. So it's a regulatory issue. And that must be looked into by government.
Thank you very much. Yes.
Well, on jaundice in children, I think that Dr. Ntadom has clarified the point that IPTs administered to the mother does not cause jaundice in the child. Jaundice is a symptom. All right? There are several things that can cause a newborn child to have jaundice, to have that yellow staining on the skin and on the eyes. When you have a child with that yellow staining on the skin or the eyes, a newborn child, the best thing to do is take the child to the hospital where the child will be properly assessed for the cause of the jaundice and treated accordingly. Also, like Dr. Ntadom mentioned, it isn't all jaundice in a child that requires treatment. And the doctors, the health professionals are in the best position to tell which is which and do what needs to be done accordingly. And just to add, to throw another light to the discussion on faith-based treatment, I'm of the opinion that it behoves government, much as government hasn't a right to determine where we will access treatment, I think it behoves government to regulate the amenities and the facilities that are providing healthcare to the public. That is an important government regulatory activity.
Absolutely.
And if a church has not been properly assessed and regulated to provide healthcare, then the government has, these are important things. We need to control, much as we want to present the options to the public to choose, we need to control the options that we are presenting to the public so that when the public makes a choice, they will make a choice to access healthcare in a place where they can get better health. If there was a projected growth from 30 years ago for those 6 companies, where should we be today? Yes. And where are we? What is the status? Sometimes those are the kinds of things that bring a jolt to people's senses. Those are the things that make people really understand how backslidden we are. There is nothing that can speak louder than numbers. When we have all this fanciful language and all these beautiful prose that we use to wrap up the terrible situation that we are in, it doesn't help any. So if you go back as you're writing your communique and you do a lot more work, just take a historical perspective. It's unfortunate that we have a dearth of information in our country. You cannot go on the internet or you cannot go to a governmental agency and get numbers and get figures with which to put your work together. But, somewhere or another, it behoves you to find that information with which to deliver your message. The Western world have perfected how to use numbers to deliver a message. I think that those are areas that we also need to work on in our country.
Well, thank you very much. Some of these things we were also supposed to be looking at today with the government, because we needed to look at a data bank. Even what they get in, do they have any record as to how they use it? Let's look at the data and things, but they are not here. Well, before long, to be another year, and we hope that if we need to get a trailer to drag them then, so we actually have them here, because they need to know what is happening. They need to get the feelings of the people. They need to know how we are thinking. They need to know what we feel about how they are handling our affairs. Because ultimately, we are the ones. Those of them who are there. Any slightest thing, they can check out and go get the best treatment. I take my treatment here. A couple of you do the same. So whatever we can do to improve our system here, and in any way we can reach them to understand that they can do better as a government of this country, I think we shouldn't hesitate. So thank you very much. I'd like us to take questions at this point in time. Comments. Okay, please just let us know your name and represent. Please, could you pass the mic down to that row there? To the gentleman up there.
Hello, I'm Taiwo Edeji from Saniji Healthcare. Thank you. Summit 2009. We see the private sector has a role to play. The government also.
Don't like to what?
The point is, you have brands that are well researched. You have brands that meets the taste and the needs of the consumers as well as the customers. If you have brands that can drive value, in time, that brand will be recognized both by the industry, the market, and the government. That's one. Two, it is the role and functions of the government to provide an environment for business. It is the role of the government to as well make sure that our local brands and products are well protected from foreign infiltrations. But at the same time, these problems come from the industry itself. Because it is same players within the same industry that go abroad and bring in those shops and connect with those shops to ensure they marginalize the system. So, you see, it's a two-way thing. We can talk about, yes, these are the roles and the functions that the government must play in the environment. But at the same time, we also must ensure that one, the pharmaceutical industry is sanitized. Two, there should be more research conducted. You don't need to really spend the heaven and earth. Yes, research involves a lot of investments. But it's not all the time that you have to spend it on research. And also, if you look at those drugs that are not issued far, go and do an analysis of it. Go and do your cost scenario analysis. Get experts in costing, unit costing, and marginal costing. Look at work out all the arsenals, and see the way in which you can be able to, like when Doctor was talking the other time, he's talking about, the option of being in the stock exchange market to raise funds, which means that, yes, you are trying to watch the bottom line, and you are cutting costs in that aspect. So there are a lot of things, the government cannot provide everything. But in terms of all we have discussed now, we need to sensitize the Minister of Information on this issue of the branding Nigeria, what have you. If the government organizations are buying products that are not being made locally, they are not trying to support us. Mm-hmm. That, we can drive that point to their ears, for them to hear. Because we must be able to encourage Nigerian industries, Nigerian pharmaceutical industries. But at the same time, a stupid government will be encouraging a non-cost-effective and efficient farm just because it's a Nigerian farm. Thank you.
Thank you. That was a comment that he made. Questions? Yes, please.
Good afternoon, everybody. My name is Emmanuel Otogo. I'm from Nigeria Bar Association in Ikeja branch. My question is this, and I would like the able discussant to assist me. The question is, how can government policy assist in eradicating malaria? That's in the following areas. I will identify the areas I will want an explanation. Accessibility of facilities, that's medical facilities in rural areas, and the provision of drugs generally, and this insect-treated nets. That's the big part of it. And again, you see, the medical information on malaria to the masses generally. So that's just my question. Thank you so much.
Thank you very much. You can take another question. Okay, please pass on the mic down there. To the gentleman in suit.
Mine is not Christian. I'm Stanley Wanko. It's just a comment to add to what my brother was saying. I strongly believe in one thing, and that's the general belief of every Nigerian. Now, there are 3 ways to eat. He said, I saw 3. 3 ways to eat is the indigenous company, the government, and we, the consumer. And if there should be some uniformity in agreement and understanding and love. Now, an average Nigerian loves his life so much, and because of that fact, does not want to risk it in the hand of so-called indigenous company. But I came to understand, I fell victim of it once, some time ago. There was a time before I take any drug, the first place my eyes goes to is manufactured where. And later on, there was a time I think God wants me to change that mentality about my country, an indigenous company too. And then I was sick. And it was to the point that I could not even look at the label again. And the drug that was brought to me was from my uncle who works with GSK. And then in that condition, I could not even ask where is it coming from. But I had to get well first. You get? So what I'm saying is we have to work on our mentality too as consumers to know that our indigenous companies are doing well. Now, for instance, I don't think of anybody here who can stand up and tell me that for some time now there is a foreign paracetamol. What we've been taking is more of, I don't know about you, it's either Emso or M&B, it's either M&B or the other one. And I don't think we've had cases of hazards caused by these drugs. So that is to say that they are doing their part in their own little way, outside the government sponsoring or supporting and all that. But then we have to also change our mentality about our indigenous company to know that, and now the general belief is that, is there anything good in Nigeria? There is a lot good in this country. I believe strongly, because some of our people goes out there and they do well. And when they go over there, they place them on a very high rank positions and they are doing well. So what I'm saying is, you also work on yourself to make sure you don't disappoint us. Now, from what you say, the man on the extreme left, all right, you said for some time now that the drugs you have in the market for malaria drugs, you don't import. That's a good one. And if all of us should go by that alone and say, okay, this is our company, let's go ahead and take it. But then, along the line, if there's anything that comes out of it, which would cause any form of regret, and somebody will say, you see, this is Nigerian product. Assuming it was an Indian product, it wouldn't have been this way. So it's 3-sided. Now the pharmaceutical indigenous companies should work harder to improve and get to the standard where I trust you, even to the point of saying, handing over our lives. Permit me to use that word, because whoever that is taking a drug is taking a risk, because you don't know what the drug will do to your body, either harm or good. It could be anything. So what I'm saying is that if you play your part, well, we owe you a duty too to patronize you. It's our country. You are our own. Unlike the way we patronize foreign companies and foreign drugs, sometimes these drugs is not as if there's anything too unique from what our indigenous companies can offer and give us. But it's just that there's a mentality we are going with. Once it's a white-headed man, once it has to do with one country outside this country, it is perfect. Whether it is perfect in the surface or not, it is just perfect.
Thank you very much, Mr. Khan. Thank you very much. Thank you very much. That was a comment too. So we'll take one more question.
Yeah, good afternoon, everyone. A beautiful summit, I must say. We've all spoken well, and in as much as, this is beautiful, there are certain, caliber of personalities that are supposed to be here. The people at the helm of affairs, our governments, or their representatives. Because we have said so much, but it's like, it's not going to get anywhere, even with the media going to report these things eventually. But I think that advocacy needs to be carried, at that extent. My brother here said the government cannot do everything for us. We are the government, yes, I believe. But there is a lot, they are expected to do in this case. They are setting the laws without implementing it and violating the law at the same time. There are body standards set. There has to be a system structure set in place for all these things to work on. We have the NAFDAC, we have the WHO one side. I don't see why they should not collaborate and come, to reason, together. Then the government, we have our private industries manufacturing drugs. The NAFDAC is there as a regulating body to foresee. I don't think that what they are producing, if it is not meeting up with the standard, it should even be found in the market. So how are we encouraging them? After manufacturing, then we go outside there to patronize people? It's not really encouraging, because the tendency is that the private sector, they are going to be frustrated out of the business. So advocacy is the key word, and reorientation of everybody, starting from the leaders and then the stream. It's going to, that should be the only solution, without which all the things we are saying here won't go anywhere. Thank you.
Thank you very much. Maybe before we lose the trend of the question asked, the gentleman, Mr. Otobo, had asked some questions with respect to accessibility and things. Maybe we'll take it now, because we seem to be having some comments.
Well, regarding access to healthcare, the government has a policy to ensure that a primary health center exists within 10 kilometers square of every Nigerian space. This target was set, I think, sometime in 2000. I don't know to what extent the Primary Healthcare Development Agency has achieved, to what extent they have achieved this objective or this target. And what that means really is when we have these primary healthcare centers close to us, the byline then was you don't have to walk more than 10 kilometers to get access to a primary healthcare center. And in those centers, you were supposed to be able to access treatment for malaria. You're expected to be able to access things like drugs for basic healthcare conditions. ITNs are supposed to be accessible in those places. We're also supposed to be able to provide basic maternal and child health care services in those kinds of centers. No, but you see, we have all of these good things, all of these good intentions down on paper. The implementation and monitoring of implementation of these things appear to be the issues that we all have to focus on. We know what we need, we know what's right to have. Now, between identifying our needs and putting those things in place, I suppose it's the gaps in those, that connection is what we need to bridge.
Yes, thank you.
If I add to that, there's guidelines, and we have the strategic plan 2009 to 2013, the federal government Ministry of Health on malaria. And in that we have the business plan 2009 to 2011. And there are many things, as you said, on paper are put. You talked about nets. I can just tell you that has been singled out from the business plan. And in the plan by December 31st, 2010, each household in Nigeria will have 2 nets. It is there, and the Federal Ministry of Health flagged off this last month, and that is all now. And by the time we give 60 million nets by December 31st, 2010, each household will have got 2 nets, and that is a policy guideline for that, for achieving that. Implementation, as Dr. Mizoyo said, is a different thing. But I just single out one so that we can really have that as a picture.
Sorry, I hope the 2 nets per household presupposes that it will be a father, mother, and 4 children.
Or mother and child.
No, the philosophy behind it is historical. At the time we started giving out 1 net per household family, we discovered that a man
will take it,
and even if he does not use it, he said, "This is my own first." So we now say, okay, 2 nets per family. When the man takes one, then at least there will be one for the wife and the children. So that's the logic.
I think they should modify it so that when the net comes in, the man should hold on. He can tolerate malaria more than the women. Okay, just before we take the next question, I would like to let you know that we have some stands outside there. Please, if you haven't had the opportunity to go around, please do make out time to do that before you finally leave the venue. So, ladies and gentlemen, you are welcome. This is the first segment, which in due course we shall be merging with the discussions on malaria in pregnancy. And that will take effect as soon as the key discussant on the malaria in pregnancy joins us. Ladies and gentlemen, you're welcome to this segment. May we give them a round of applause, please? Yes, on this segment, we are actually going to take a look at what's happening. As you all know, we have all the time a first-line drug that we use normally for the treatment of malaria. To find out how we have been doing with this first-line drug, there are a couple of questions we shall raise. So please join us as we take a tour of the issue of malaria with respect to what we know and the problems that we have been encountering, and perhaps do we have data bank on what is happening with our use of the first-line drug. That is the aspect we want to look at. And you have the opportunity to ask questions. If there's anything that's been bothering you, if there's anything you think you need to know, because we're also talking about the right of the patient to know. The patient who gets to hospital, does he have a right to know about the drug he's given? Does he have a right to know how he's affected by this drug? Does he have a right to know the side effects? In other words, if he asks the questions, does he have a right? Is he entitled to answers to those questions? Of course, these are some of the things we are going to be raising. So it's not just about you being sick. It's not just about you submitting yourself to the doctor at the hospital. It's also about you knowing what drugs you are giving. It's about you knowing what rights you have as a patient. So you're welcome, please. Madam, I would like to begin with you. Let's just briefly, talk about this first-line drug. When we talk about first-line drug in the treatment of malaria currently in Nigeria, what are we talking about?
Well, currently in Nigeria, the first-line drug is the artemether-lumefantrine combinations, and they come in different trade names. They are used by all, they can be taken by almost all malaria patients, and the doses are graded according to age, with from infancy, 5 kg child up. Can take artemether-lumefantrine. They come in tablets. Some are in powder forms to ease out the dosage. I said the first-line drug for malaria in Nigeria, according to the National Anti-Malaria Treatment Guideline, is artemether-lumefantrine combination. And then different formulations for ease of administration. We have them in tablets, we have them in powder forms, and they can be taken by children and adults alike.
Okay, thank you very much. Mr. Yusuf, let's ask you, do we have these drugs readily available? Are they accessible? Can we reach them?
Yes. NAFDAC has approved the combinations of artemether-lumefantrine as a first-line treatment, and also other artemisinin combination therapies. Presently, we have over 54 brands that are in the market officially.
Yes, we're talking about the brands, the brands in the market.
Yeah, that's what I said. The brands are up to about 54 in the market from different companies, in the combination of artemether-lumefantrine and artemether-amodiaquine, other artemisinin combination therapies.
Okay.
For the artemether-lumefantrine, I think at the moment we have about 3 that are on the market. But government approved, in the malaria, anyway, my colleague from the malaria program can talk about within the program what they use or their preferences. But for us, what we have put on the market as the National Drug Regulatory Authority are about 54 combinations of the artemisinin combination therapies.
Okay, Dr. Godwin Tatum, let's now, you really belong to this rollback malaria from the what have the so far in terms of working to see that if we're talking about rolling back malaria here in Nigeria, that we actually have this drug available, that we also have it accessible, because we need to know, people need to know what you have done.
Thank you, moderator. Good morning, ladies and gentlemen. Like I said, the question that was put forward is on the issue of the anti-malaria recommended. Like as you said, we have a lot of artemisinin-based combination therapies. The body of medicines that are now used to treat malaria are regarded as artemisinin-based combination therapies. Out of these, a country is expected to select 1 or 2 that it can adopt for the treatment of malaria. And Nigeria has selected artemether-lumefantrine, like I've been said, and artesunate-amodiaquine. Then it is now left for the pharmaceutical company to call it whatever you want to call it. But these are the generic names for these medicines. And coming to the availability of these medicines, one of the responsibilities of the federal government is to provide treatment. And the federal government, supported by several partners, agencies, global bodies, have been able to provide some substantial quantity of anti-malaria into the, have been able to provide facilities. But like I said, Nigeria is a very big country, and to provide all facilities, all the individuals having malaria is a big problem. Because when you begin to estimate the number of people that fall sick from malaria in the country, it's almost the entire population. And it's not just getting sick, it's like an individual can be sick twice, 3 times, 4 times in a year. So we really need a large volume of anti-malaria to be able to provide to this population.
So are they available? Are they accessible? Are they affordable?
For availability, they are available. And for some of the states that have been benefiting presently from the support we are receiving, they say they are accessible. But generally, because these medicines, they are new and the production, which pharmacists will talk more about, is quite expensive for now. But the federal government is actually putting in a lot of measures to ensure that the prices of this commodity come down compared to what chloroquine is now in the market.
Okay, thank you very much. Dr. Let's actually look at what is happening. You are from the Nigerian Institute of Medical Research, and you're also an entomologist. Now, let's go further. These first-line drugs, what information do we have about them? Going back to studies, going back to research. In terms of usage, in terms of effect on Nigerians, are we putting it together? Are we documenting the effects? What do you have in terms of information about these first-line drugs?
Well, thank you very much, Mosito. Like you said, I'm working at the University of Medical Research. And before I come back to your question, our research at the University of Medical Research focus more on preventive measures. What are the things that you can do to prevent malaria, prevention, disease, and cure? And our research focus mainly on the mosquito that transmits the disease. What are we doing to prevent mosquito from biting human? Are there alternative way to do this so that the mosquito will not recognize human beings? These are some of the things we are doing. It's very funny, you know. But then this is the truth. If you can disrupt the mosquito from recognizing human, then there's no infection, there's no transmission. And back to your question.
That's an interesting one, really. Let me take you on. We'll come back to that question. But it's an interesting thing, you know, mosquito not to recognize humans. How are we doing on that? You know?
Right, that's a long story, but then let me summarize the whole show. How does the mosquito actually recognize human? You have one who eyes out. No, they recognize human by the odor of the lips. They recognize human by the CO2 that comes out from the human, by the odor of ammonia that comes out. So, is it possible to synthesize this compound and try to put this compound in traps so that the mosquito will be attracted towards these traps? These are some of the innovation that comes to it. And there's a consortium in the US that is fully involved in this now. They've seen that there's no vaccine for malaria, drugs are cured, there's symptom resistant, there's insecticide resistant, all kinds of resistance coming to it. So what is there any other measure that we can put in place that will disrupt the mosquito from recognizing human? You know, part of the net, which the fellow colleague Daniel mentioned later. There are a lot of problems with net, the availability, all that things. So research is going towards trying to see, okay, you don't want to use a measure that fails for so long time. So these are some of the things that is coming to research.
Okay, so back to the question we now asked. We're talking about monitoring the use of these first-line drugs. Well, you are told that not actually your area, you're not concerned about preventing malaria, which is very, very good. But perhaps we could have your opinion on what we have been doing in terms of monitoring the use of this drug. We'll come back to use that to tell us that.
Right, and there's a unit in our research that's involved in working on dogs, and they are documenting all available drugs in Nigeria as well. And another record, the current director actually is keeping in that area and to look at what are the drugs, like the available drugs, and what are the pharmacovigilance of the drugs, and so forth. But in time of saying that availability of this drug, I'm sure that my colleague from the National Medical Program says something like that. But in our own setting, they have seen that the cost of the drug, the availability of the drug are available, but in terms of cost affordability, and the issue.
Okay, so let's like to comment on that question.
Well, what I want to say is that from the National Agency for Food and Drug Administration and Control are mandated by law to regulate and control the distribution, use, and sale of these drugs. And in carrying this mandate, we try to put structures that will first track distribution and track the use and report, including adverse events coming out of the use of these products. The National Drug Policy has stated very clearly how this goes out. And what we do in that is this. First of all, we license products to be in the market. And we make sure that they remain informed from production to the user, so that the quality is as it is produced. Now, there is a national treatment guideline, and we ensure that treatments follow the national guideline. And in the event of treatment, if there are any adverse events coming out, we report these adverse events and are classified. In severe cases, we direct even withdraw a whole product from the treatment line. We'll take it off the shelf.
Okay, sorry, sir, let me just ask you, how have people reacted to this facility? Have you been getting reports in terms of the reaction of people to these first-line drugs?
Yes. Currently, from our database, we have up to 71 reports of adverse reactions coming from the use of administration-based combination therapies. But then these are, apart from the one coming out from the use of amodiaquine, which is a little severe, all the others are moderate adverse events, and they do not warrant withdrawal of the products because we do what we call a PR, risk-benefit ratio. So if the benefit is higher than the risk, we allow the product line in the market to be used in the system. This is our responsibility as a regulatory agency. Also, I want to add, What is in the Nigerian system today is not only ampicillin-based combinations, I feel like my colleague from the malaria control program has said, but they are the first-line treatments as recommended by government. But still, there are other products you find in the market, like the chloroquines, like spotazimifene, which by the time we come talk about the use of these products in pregnancy, we may have to make some emphasis on them. So these are the facts that are there.
Okay, Dr. Ntad, let's look at the National Malaria Program. You heard what you told us now. They actually have a database. We're taking a database, collecting information on how Nigerians are reacting to these first-line drugs. Because we started that way, some remember, gradually we're getting to know about resistance to drugs. I would like to know, do you have a unit doing similar things on the National Malaria Program?
Thank you very much. We are all in government and there's no duplication of activity. Rather, we collaborate together to achieve. When you are talking about anti-malaria, the National Malaria Control Program, what is interested is one, sensitivity of that medicine. That is ability of that particular medicine to clear the parasites. That is to heal the individual that has malaria. Then the second one is that this medicine is it able to give us problems? That is, we are talking about adverse drug reactions associated with that medicine. And these two have to be followed. One, the National Malaria Control Program has sentinel sites. Sentinel sites they are like research centers where regularly anti-malaria medicines are moved to these sites, and when patients are treated, they are followed to find out whether this medicine is actually doing what it is doing. Then again, during the process, we called also if there are some other untoward effects that are associated with this medicine. Then the area of pharmacovigilance, the other part is what we are talking about pharmacovigilance. We want to know whether there are some other problems associated with that medicine. So what we do is we work closely with NAFDAC. And presently, what with NAFDAC, we put to establish 6 sites in the spread over 6 occasions. We mainly supply anti-malaria and collect data. People use medicine and they come back with the report whether the thing is okay, whether they react in one way or the other. So we have a kind of bank of information that is guiding us. And that's what's going to determine whether the medicines will continually be used or will be withdrawn. Then again, it has to be sensitive. That is, the resistance level has to be very low. And also, that is another thing that is guiding us. Anytime we are moving away from this our objective, or the medicine is no longer effective as a result of high resistance, or is no longer clinical as a result of several side effects and adverse drug reactions, then the federal government will now move from new things to new medicines introduced.
Okay, but like I said, so far, how do you rate the response? Is it at the level that, no cause for alarm? Is it at the level that we really have to be on the watch out? Is it a level that we need to have carry out, a more study, into these drugs, so as to know that we are actually on the right track?
Yes, globally, the artemisinin-based combination therapy, they are new medicine in the, when you're talking about medicines. It has been in use in China for several years as local and herbal products. It's the whole idea of putting into medicine is less than 30 years old. And again, experience with its use is so limited in Africa. It was because there was no other alternative, or a good enough alternative, that's why it was introduced. And that is why we don't have enough data to actually show all these other side effects. And that's why we have to, as we are deploying it, we're only following it up pharmacovigilance to study it. So that's what we are doing presently. The question you are trying to, the other part of the question you asked.
With respect to what we're trying to find out is this. Are we at the level where we can say, well, it's okay?
Okay,
are we at the stage?
Like a malaria program, program malaria is based on evidence. You need a lot of evidence. What we have recently is what scientists will call an anecdotal report. Somebody used it without any documented evidence. Say, oh, is this, is that? Until we are able to confirm by way of research that yes, these people used it and it led to this. Then we'll not be able to act on that. And that's what the core event monitoring of pharmacovigilance will provide us. Once we're able to collect enough data, we'll be able to say, yes, this medicine from the report, out of the 10,000 people we give, these people have a problem. Out of the 3,000 we give, these people have a problem. We make a deduction.
Thank you very much. Mr. Lawal, you belong to the Pharmaceutical Society of Nigeria. Yes. Okay, I'd like to ask you, how does your association collaborate with those various government organs, to see that Nigerians are consuming the right drugs, to see that we are actually, it's true that these drugs are new, and listen, we are at the level of gathering information. To what extent is your association collaborating to see that we are on the alert and we are seriously engaged in this pharmacovigilance so that we are not taking on our words?
Thank you very much. I'm representing the president of the Pharmaceutical Society of Nigeria, and the much I know is very much in collaboration with others. In Nigeria, there's a lot of promotion of care integration. But at the community level, along, we also have pharmacovigilance forms to report adverse drug reactions when they occur. But sometimes it's not easy because I think the patient is taking this drug, taking some other things. And you're not even sure what the patient is actually reacting to, apart from herbs, concussions, and all that. I know in this country, so many people like.
Okay, so you're saying that we have a challenge that the patients, who could be very, very well, and any one of us here, there's no challenge that at the time I'm coming to a doctor to treat me, I'm also taking some other herbs, and I'm also taking some other, I don't know. Now, so at the end of it, it gets a little more complicated. So if we're not talking to, because it's not just about something other things, it's about you and I getting to know that these problems exist. It's about you and I being able to also take the message across to others. Now, let us look at the role of the Nigerian, the role of the patient. Does it have any role to play, in the effect to see, in the effort to see that ultimately we actually have the quantum of information, the data that would help us to have direction, that would help us take necessary decisions that we must take. Doctor, please, can you help us on that?
Well, let me put it this way. For control of malaria, there are 3 key issues here. The first issue, you have of the drugs associated issues. The second issue is that of the mosquito that causes the disease. And the third one is the human being that affected by the disease. And the first thing here to be very important is that the behavior of the human towards the disease. This is a material that we have produced for years now. So many of us are not doing those materials. So the human being that is affected by the disease must change his own thinking about the disease. And there's several things that I'm to mention here. The environment is there. The way we keep the environment also allow the mosquito to breed. And infection, that you have a wonderful dog I can say for 100 years, it will be infection treatment. That's not what we want. We want to make sure that they don't have malaria. Now, as I've said, it's a long story, but in Europe, for instance, don't they have mosquito that transmit the disease there? They do. They're able to get a scenario, phenomenon, which they call anopheles without malaria. And how do they achieve that? There are many put in place. After they were able to remove the parasite from the population, they are measured. They put in place that make sure that this continuous transmission as well. And the human being